Right, thank you very much for staying. And I'll try to shout a bit louder if I can. And I'll ask you to talk about the evidence for and against stenting in patients with connective tissue disorders. And I thought about it, what to talk about it. These are my closures. Actually, that will be it, and we can go home for our dinner, actually, because very, very little evidence, and definitely level 1 evidence to support either way. People trying to use indirect evidence to support their practices. Nevertheless, we look at a few things that we should. And incidence of thoracic aortic aneurysm and dissections, every time they do the population studies, and you can find it's increasing. But saying though, I was told by vascular surgeons that there's an incidence of abdominal aortic aneurysms are reducing. And maybe because of the statins and secondary prevention. So we need to look at that. And we know more and more about genetics. And then so we know more about the familial thoracic aortic aneurysm dissections and the association with Marfan's, Louis D's, vascular Ehlers-Danlos, and Turner syndromes, and then there are more and more patients around in our aortopathy clinics. We are seeing these horrible gold standard operations, and Lars has just shown the kind of very, very extensive kind of the whole aorta replacement to the open surgery. And then that's been a whole standard that we all been kind of accepted it for years. But since around 91, when Jerome Berardi's introduces infrared or kind of aortic stenting, the dream of a minimal access, and then the non-invasive, really, well, invasive, but for the stenting is coming in place. And subsequently from Stanford, and they published a paper about the thoracic endovascular stent grafting in 94. And in the about 14 patients had that thoracic aneurysm stenting. That's led to expansion of thoracic endovascular stent grafting and more all over the world. Simple, mid-descending thoracic aortic aneurysm with a decent landing zone proximal and distal. Stenting is by far probably the simplest and probably lowest kind of risk procedure for patients nowadays, and that has changed. And we have many thoracic endovascular stent graft available nowadays. And branch stent graft, fenestrated stent grafts, and then them coming kind of more and more kind of come into practice. And you're seeing a hybrid arch repair with a kind of open surgery and there's a stent graft kind of together. Or the way that kind of Cleveland Clinic does it, their frozen elephant trunk type of procedure. There are a variety of ways of using stent graft in these these aortic aneurysm patient dissections. And now more recently, more branch arch stent grafts are coming in. So we have more and more facility available for stent grafts and to treat these patients. So when you look at evidence for endovascular treatment in acute and chronic aortic pathology in Marfan's, and the paper they've seen, 16 patients in the paper, 19 patients underwent the TEVAR, EVAR, and they come to the conclusion that endovascular treatment can be used as adjunct or a bridge to open surgery. And subsequently, kind of more recently, systematic review by the David from the Roberto's group has a systematic review of 12 papers. Combined 12 papers come with 54 patients. And out of that group, 81% of the landing was stent graft was landing in the native aorta. And then 1.9% dead, and the CVA 1.9%. And then paraplegia was similar incidence. And conversion to surgery was only 3.7%, but endoleak was 22%. What it shows is endovascular treatment can be performed in these patients with a low risk and relatively low complication rate, but trade-off is endo leak and subsequent reintervention problems. We've seen a look for the paper. There was a paper for Ehlers-Danlos syndrome with 26 patients over 16 years time period, and 48 procedures performed at very low late complication rate, about 2.1%. But this is over 16 years from the one group. And so the evidence, when you look for it, is quite difficult to find. So what are the problem with the connective tissue disorders patient? They're young. They have weak aortic wall. And so it is when you have a kind of stent graft with metal kind of spikes, the chance of tearing, retrograde type A dissection, and subsequent, even they don't have a dissection, subsequent false aneurysm in these areas when they have a trauma, or the aortic expansion in around the peri-stent area and lead to late endo leak subsequently. And the complication of these aorta occur is quite smaller size. And there are quite a lot of patients have type A dissection at a size less than 4.5 centimeter. These are a group of patients that we're talking about. And they require multiple intervention in their lifetime. So there are the multiple problems associated with them. So retrograde type A dissection has been quite not being discussed before, and they depends on the CV. It's a measure, it cannot present it between 1.3% to 6.9%. Not as high as we expect to, but once you have a dissection, retrograde type A dissection happen to descending kind of uncomplicated type B dissection. And then type A repair internationally, mortality is around 24%. So uncomplicated medically treated and type B dissection with mortality of less than probably 10% or 5% can be converted into over 20% following type A repair or retrograde type A. So they need to be considered appropriately. And they have complicated kind of problem, and they come back with a kind of interposition ascending graft, and come back with a kind of subsequent root aneurysm, distal arch, and descending aneurysm, and septum calcify. So variety of these things happen, and then this patient had the previous ascending. And you can see the root, and they can arch, complicated section, and all the way down. So these patients have a kind of multiple problems. So when you're trying to kind of look at the evidence for and against for stenting for this kind of patient group, it's not straightforward. And then many of those patients that we are seeing in our clinics, and that they are not ideal for endovascular stent grafting. And then pliability of these septums. This is a patient with a septum remain pliable 2.5, 3 years after initial dissection. So what we think traditionally that after about 9 months or so, there will be kind of no more pliability of septum. That's not necessarily true. So we can treat that kind of patient with endovascular treatment as well, possible. So we need, there are so many factors involved when you cannot come to interpret the outcome of the kind of treatment modality. And we all seen it with the explosion of T-bar for type Bs, and they have this distal endo leak and continued expansion of false lumen, and subsequently lead to either a subsequent stenting and the coiling to stop the kind of endo leak, or maybe the open surgery. We had this one young kind of patient who was a lawyer, and they was executive and the director, member of the board in the hospital. Had the previous route for Marfan, open repair for infrarenal, and then open repair for TAA with a visceral patch, and become a visceral patch rupture, ended up with kind of multiple kind of stent graft. And then, despite of that, the rupture part of the stented aortic section, the segment, and require the subsequent redo descending and the arch replacement, probably about 18 months ago. So this is the top of natural history we're seeing with these patients regularly. So, what's the role of endovascular therapy in these patients? We heard about the kind of, to save the patient is more important than doing the gold standard operation sometime. So maybe that I would say To expedite the repair, to save the life, it's more important than kind of to go standard treatment sometime. And then trauma, so trauma patient, rupture aorta, and putting the endovascular stent grafting is good. I think that will save the life, bridge the kind of for surgery. Exclusion of patch aneurysm, or treatment of the kind of complication from anastomosis, failures, which is the right thing to do. And the key principle of success in endovascular therapy in these patients is stenting across between graft to graft. Open either surgical graft or stem graft. So you have a solid proximal landing zone, solid distal landing zone in adequate length. And that will then help you to have a kind of reasonable success in these therapies. Then we all heard about the role of frozen elephant trunk. Even though we said well, there's not a lot of evidence, but think about it. Quite a lot of patients who have type A dissection are the patient with connective tissue disorders. So this is indirect evidence that we are producing, and over recent years. It provides a proximal landing zone for the TIVA, or you can clamp a repair, it's an open repair afterwards. It certainly cannot help with the remodeling proximal descending thoracic aorta. And they're suitable for second stage either technology, that's a reason why it's becoming more and more useful, kind of two devices. But you need to know the device, either Avita Open Plus or the kind of Thoraflex and a hybrid system, whichever will be useful for individual patients. And this is one example of uncomplicated type B dissection. And this is treated with a TIVA. Patient was uneventful discharge, and then 8 weeks later came back for clinic for the routine follow-up, did a CT scan, shows a retrograde type A dissection already, and subsequently expand. So the patient came back, so we did kind of the mini sternotomy and the frozen elephant trunk into that TIVA and treated and replaced the ascending and then kind of frozen elephant trunk. So having these devices help us to treat these patients in a more effective way. But when you look for the evidence to either way, to pro or the con or the for or against, there's no clear answer for that. Which Lars has shown that his expert consensus clearly say that kind of for these patients with connective tissue disorders, endovascular stent grafting should be limited to patient with a high risk for open surgery. So I'll conclude by saying there's no substantial evidence for or against stenting the patient with connective tissue disorders. And the lack of long-term outcome data and the increased reintervention rate at present, and then make us to stick to the principle that at present therapy should be limited to patients with high-risk surgery, and also to save the patient's life and therefore bridge to open surgery. Thank you very much.